Welcome. My name is Jacqueline Barrientos, and I work at the Northern Health Cancer Institute at the CLL Research and Treatment Program in Long Island, New York. The topic of today will be sequencing decisions using current therapy options for CLL. So the objectives of this talk include reviewing the indications of treatment of relapse refractory CLL. I will be reviewing the FDA-approved medications and also highlight some of the new therapies under clinical development. Importantly, I will also mention what are the adverse events and characteristics of patients' comorbidities that may require you to think which drug to use next. We will also mention what would be the sequence to use after different regimens when used in frontline therapy. So this schema gives us a glimpse of how the field of CLL has evolved over the last 5 years or 10 years. We moved from chemoimmunotherapy approaches to now targeted agents, and we now have data to support the use of targeted agents as a more effective therapy and safer in patients with chronic lymphocytic leukemia. It's very important to know that even though most patients will relapse with CLL, you still have to wait for IWCLL guidelines until there are symptoms to require or indicate that there's a need for therapy. It will be the first thing as we did during the first-line treatment. We don't treat just because the white blood cell count goes up. We wait until there's evidence of marrow failure, and that is exemplified by anemia with a hemoglobin less than 10 or platelets less than 100,000. We also treat if the patient has enlarged or progressing lymphadenopathy or splenomegaly that is causing symptoms, and if the patient is having autoimmune complications, including anemia or thrombocytopenia that are poorly responsive to corticosteroids. It's also important to know that these symptoms can be very debilitating. These include fevers, 101 or higher for over 2 weeks, significant weight loss, more than 10% of your body weight in a short period of time, or night sweats. So what you always have to do, not only at the time of diagnosis, but also at the time that you start to think about treating for the second or third time, is to check the molecular cytogenetics of the patient. The most important one is deletion 17p, and this is because these patients have a shorter time in remission, and it's very important to understand whether or not there was clonal selection. When you have a patient with a new diagnosis of CLL, less than 10% of them will have a deletion 17p. However, the more prior lines of therapy, this number and percentage of deletion 17p cells will be enriched, with some series reporting 30% or 50% of patients having a 17p deletion over time. It is a clonal selection. So there's no doubt in anyone's minds that Bruton tyrosine kinase inhibitors are here to stay and have changed the treatment paradigm of patients with CLL, not only in the USA, but all over the world. In terms of what drugs do we have available in the United States, include ibrutinib, which is the first in-human first-line therapy approval, category 1 by NCCN guidelines for patients with a deletion 17p in CLL, and also for patients with CLL SLL diagnosis. It's also approved for Waldenstrom's macroglobulinemia and an array of other disorders and conditions. Acalabrutinib is a second-generation, highly selective BTK inhibitor, which recently got full approval by the FDA to be used in frontline therapy with CLL patients and in relapsed refractory disease. And there are some other drugs in the pipeline that are pending approval and are currently accruing for clinical trial participation. Zanubrutinib has been already started phase 3 trial studies in patients with CLL, but it's not yet approved for CLL. And there are a new category of group of BTK inhibitors, mainly the non-covalent kind. These ones are important because there is the theoretical idea that these drugs could work in patients that develop a BTK mutation and are no longer responding to a BTK inhibitor, the typical ones, the covalent ones. So let's go back to the initial data. Ibrutinib was approved initially for relapsed refractory disease in the RESONATE trial. This was a trial that compared one-to-one randomization of ibrutinib against ofatumumab in patients that had comorbidities or that would not be able to tolerate the purine analog. As you can see, there was a significant advantage in terms of progression-free survival and overall survival for patients randomized to ibrutinib. And this trial allowed, at the time of progression of disease, to cross over to ibrutinib if you had been randomized to ofatumumab. In terms of the 5-year follow-up, what we see is that at 5 years, the median time for progression-free survival for ibrutinib has not yet been reached. And it's important to know that over time, the longer that you take the drug, the responses become deeper. More of the patients that initially had partial response with lymphocytosis then become partial responders, and even there's a minority of them that can achieve a complete remission. The overall survival is not reached with ibrutinib treatment. As you can see, at the time of the follow-up, we still haven't achieved or reached the median overall survival. Now, let's talk about acalabrutinib. It was recently approved based on the ASCENT study trial that was presented at EHA 2019, and the approval came in November of 2019 by the FDA. It was tried and tested in patients with relapsed refractory disease. And this was compared against 2 standards of care. One was the regimen bendamustine and rituximab, or idelalisib with rituximab. The primary endpoint was progression-free survival. In terms of the outcomes, as you can see, by independent review committee assessed progression-free survival, there was a superiority of acalabrutinib against idelalisib in combination with rituximab or bendamustine in combination with rituximab. The control groups had very similar median PFS to historical controls, and the median PFS for patients treated with acalabrutinib was not reached. In terms of overall survival, there was no major change at the time of the presentation. The median follow-up has been 16 months, and the median overall survival has not yet been reached. 51% of the patients who were randomized to idelalisib or bendamustine and rituximab had documented disease progression and were allowed to cross over to receive acalabrutinib monotherapy. So that's important to remember, as this may be the reason why we don't see at this time an overall survival advantage. Now, let's go to the BCL2 inhibitor Venetoclax. This is a novel agent that was tried and tested in combination with the monoclonal antibody rituximab in the Murano trial. The study was for patients with relapsed refractory disease, and the patients received Venetoclax first over a 5-week period. And the reason why you need a ramp-up schema is because in the original phase 1 trials, we saw several cases of patients developing tumor lysis syndrome. And so in order to decrease the likelihood of getting the tumor lysis syndrome, you go 20 milligrams, 50 milligrams, 100 milligrams, 200 milligrams to a target dosing of 400 milligrams. So you get the Venetoclax at target dosing at 400 milligrams, and then you continue once daily for a total of 2 years from day 1, cycle 1. And you add rituximab for a total of 6 cycles, and then you stop. So it's the first combination treatment strategy that is fixed duration dosing. And what we saw was that even after finishing and completing therapy, there was sustained response in patients treated with Venetoclax and rituximab, with a 4-year PFS of 57% to patients randomized to Venetoclax and rituximab. The overall survival benefit was maintained even 2 years after end of treatment, with a 4-year overall survival to patients randomized to Venetoclax with rituximab at 85%. Now we move to the other category of targeted agents. These are the PI3K delta inhibitors. Iadella was the first one to be approved, and this was approved in combination with rituximab based on trial 116, where they tried patients with relapsed refractory CLL and then randomized them to get either rituximab, a single agent, for 6 months, or rituximab in combination with idelalisib. Now, many physicians, when they see this trial, they are concerned that rituximab is not a great comparator, but the patients that participated in this trial were the sickest of the sick. We had patients with 0 platelets that were still able to participate in this trial. So this was a very difficult to treat group of patients that would still be treated with rituximab alone. And that's how the FDA approved this type of regimen. At the time of progression of disease, patients were allowed to be unblinded and crossed over to receive idelalisib. And what we found with this trial was that idelalisib and rituximab, the median PFS was 19 months compared to the placebo of 6 months. The issue with this particular type of agents is that many of the patients stopped having being able to take the drug because they develop severe autoimmune complications, including colitis, transaminitis, and pneumonitis. So even after we got the approval for the second PI3K DeltaGamma inhibitor, duvelisib, which was compared against ofatumumab as a single agent, we saw the same. Even though there was a median PFS of 13 months, many of the patients sustained the same autoimmune complications that we saw with idelalisib. And this is for the reason why we're using these drugs kind of like more as a third-line agent or later. Now, zanubrutinib is the other BTK inhibitor that I mentioned earlier that is now currently undergoing phase 3 trial testing to get approval in patients with CLL. And as you can see, very good response rates and seems to be a very promising agent in terms of progression-free survival. Now, I wanted to mention a new drug, the non-covalent BTK inhibitor LOXO-305. This was presented by Dr. Anthony Mato at ASH last year. And it is a drug that is now on phase 1 trial, but even though at phase 1 trial, we're seeing evidence of activity in patients with progressive disease on a BTK inhibitor. So this is very important because we don't really have many agents that can salvage a patient that progresses with a BTK mutation. So we should continue to watch closely this agent. The overall response rate in all patients treated with CLL was 77%, with the majority of the responders being partial remission, and the responses deepen over time. Now I need to mention CAR-T. This is the drug lysocell JCAR017. This type of drug is engineered. It's a vector where you take out the T cells of the patient, you re-engineer to identify CD19 cells, and then you put them back into the host, and the patient has the T cells proliferate in its own body, and his own T cells can then attack the leukemia. So in patients previously treated with ibrutinib, this is a presentation of 16 patients. You can see that even in patients that had a previous progression to ibrutinib and Venetoclax, the response rates were really good. Overall response rate was 81% amongst the 16 patients with CLL treated on this trial, and 44% of them were able to achieve a complete remission. So this is a very promising regimen. The only issue is that it requires a lot of support because you can get cytokine release syndrome or neurological toxicities, which may require ICU admission. So it is interesting and promising, but we only use this type of agent on our patients that have failed every other therapy at this time. So in terms of potential treatment options based on the frontline therapy, it all depends on what you have had before. If you have a patient that received chemoimmunotherapy regimen, such as BR 10 years ago, and the patient is now relapsing, it would be reasonable to consider giving the patient again another round of chemoimmunotherapy because they achieved a very long remission duration. So these are the possible treatments, including clinical trial, which is what we always recommend, BTK inhibitors, Venetoclax, or PI3K inhibitors. Similarly, if you have been treated with a BTK inhibitor frontline and you stop responding, you can be using Venetoclax as a salvage therapy or an alternative BTKI in the case of patients that develop an intolerance. But you have to check for a BTK mutation because at the current commercially available alternative BTK inhibitor will not respond in patients with a BTK mutation. And again, we have to mention the PI3K inhibitors, but these drugs, because of the toxicities, have kind of fallen out of favor. And if you start the drug Venetoclax for frontline, then you can transfer over or crossover to ibrutinib. This is kind of like a small schema that importantly shows that you have to determine the next line therapy based on whether the patient is progressing or is intolerant. If the patient is progressing, you have to remember that these patients will not likely respond to a second generation BTK inhibitor unless it's a non-covalent compound. And so you have to treat with an alternate type of therapy. If it's intolerance, you can actually salvage them with a second generation BTK inhibitor. So how do we choose when we have so many options? It depends on the patient's comorbidities, whether the patient has cardiac issues, renal issues, and what medications they are on. So putting it all together, these are the side effect profiles for targeted agents. This is a comparison of patients treated with ibrutinib or acalabrutinib in the randomized phase 3 trials. And excuse me, what you can see is that importantly, they're very similar in terms of toxicities, but acalabrutinib seems to have a little bit of an edge in terms of tolerability, with less events of severe grade 3 hypertension or bleeding and atrial fibrillation. So there might be a little bit of an advantage to having a more selective BTK inhibitor. But the real trial will be when we have the results from the phase 3 ibrutinib against acalabrutinib trial, which is still ongoing. And it's been ongoing for many years because both drugs are really good. Now, in terms of Venetoclax, the most important thing to remember is the tumor lysis syndrome. You need to bring the risk down. So what we do is debulking strategies. We sometimes do monoclonal antibody first. We debulk, we bring the white blood cell count down, and then we do the Venetoclax. And you always have to follow the ramp-up dosing schema strictly because you could potentially cause harm to the patient. And then for idelalisib and duvelisib, again, it's very important to recognize that here what we see is that these patients have autoimmune issues, including colitis, pneumonitis, and transaminitis that can be severe and even fatal. Fatal infections have been reported with these agents. So for patients with cardiac comorbidities, always consider Venetoclax prior to a BTK inhibitor. For patients with renal issues, consider using a BTK inhibitor or monitor closely with Venetoclax. For patients with autoimmune conditions, consider using a PI3K delta inhibitor. If you are doing so, you have to do close monitoring. And for concurrent medications, always try to involve your pharmacist. Now, what other factors should be taken into account? Do the patient's frailty, do they want to be in the hospital, and do they want indefinite therapy, or do they prefer treatment strategies that are time limited? So in conclusions, there are many options available for our patients with relapsed refractory CLL. We always recommend trying clinical trials first. If that's not possible, then determine what are the specific patient factors that will drive your choice for therapy. And we need more research into sequencing strategies to determine what are the optimal lines of next line therapy. And with that, thank you very much for your attention.